Welcome to a presentation that addresses select topics about the integumentary system and specifically addresses certain characteristics of products used in the practice of wound healing. My name is Jim Patrizzi, and I'm a physical therapist that practices wound healing and edema management. As the largest organ in the body, the skin provides many functions without which we would not be able to survive. Whenever the skin is compromised, there are multiple risks to the long-term health and well-being of the individual. Each of these healthy skin functions serves a specific purpose and must be protected or restored. Skin comes in many forms and is exposed to many factors that may challenge us as practitioners of wound healing. Wounds involve some type of insult or injury to living tissue. They may be open or closed. This slide lists some of the more common types of closed and open wounds. As listed here, it is helpful to address the following. Treat infection. Keep wounds clean. Consider both systemic and local factors. Pressure reduces blood flow. Patients should change positions often, using cushions or splints when appropriate. The wound environment should be moist, not wet, and not dry. Remember, if it dries, it dies. Proper diet is important, as well as controlling blood glucose levels, being hydrated, refrain from smoking and other behaviors that have a negative impact on healing and health, and use supplemental oxygen when indicated. We should choose dressings that shield wounds from the environment. It is important to optimize the vascular state by addressing arterial, venous, and lymphatic disease. We are learning much more about the cellular components of normal and poorly healing wounds. Technology is paving the way to create dressings that address the cellular needs of wounds that we are attempting to heal, rather than just covering them. And lastly, it's essential to manage comorbidities as they play a significant role in the ability of a person to experience wound healing. We know that the appropriate dressing supports the normal wound healing process. In addition, dressings that desiccate a wound will contribute to a much slower rate of healing. A classic example of this is the use of wet to dry gauze dressings, which we strongly discourage for the treatment of chronic wounds. Wound care dressings are composed of a wide variety of materials meant to meet the needs of the wound environment at a specific point in the healing process. When using compression dressings, we must avoid applying too much compression for the level of arterial insufficiency that may be present. In the next several slides, I will review several wound care dressing categories, offering comments on the indications, advantages, and disadvantages of each, as well as provide examples of each category. It should be understood that most dressings can be considered to either be a primary or a secondary dressing. The primary dressing is the product that is in contact with the wound surface itself. Secondary dressing is the covering over the primary dressing. There are products, however, that serve as both a primary and a secondary dressing, which I will indicate when appropriate. For the sake of this presentation, my comments are derived from the table on this slide as well as the next. It's not by any means an exhaustive, comprehensive list of all wound dressing types, but it does contain the most common categories of wound dressing products, which are continually evolving. The practice of wound healing, which necessarily involves dressing products, requires that the dressing products meet the needs of the wound, which should be changing as the wound heals. There certainly is no one perfect dressing that will take a wound from its early stages to complete healing. Constant reassessment is required to promote the best possible outcome. Gauze products are the oldest form of wound dressing. They are available in many forms, from tightly woven strips for packing wounds to woven sheets and rolls. Gauze may be coated with various products to impart their action to tissues that they contact. Although cotton gauze is an inexpensive and widely available material with many uses in healthcare, there are certain limitations to its appropriateness, just as there is with all of the other dressing products. It may serve as both a primary and a secondary wound dressing. However, oftentimes the disadvantages outweigh its advantages, and other products should be considered. In years past, you would very often find orders for normal saline wet to dry gauze dressings. By definition, this dressing is meant to be applied moist, allowed to dry and adhere to a wound base, and removed later, taking with it whatever tissues were adhered to it. This is a very traumatic and non-specific method of debridement. Most practitioners writing such orders probably do not intend for their patients' wounds to be abused in such a manner. Nevertheless, this is the legal definition of a wet to dry dressing. The vast majority of well-informed wound healing practitioners no longer perform wet to dry dressings, as the products to promote debridement and healing are much more sophisticated since the days when wet to dry dressings were commonly used in wound care. Because the wounds were allowed to dry out, which contradicts the moist wound healing model developed in the 1980s, wounds took much longer to heal with that practice. Calcium alginate dressings are intended to both absorb significant volumes of exudate as well as to not dry out a wound surface. This may seem contradictory, but it is the properties of the dressing material, which is derived from seaweed, that allows it to maintain a moist wound surface while transmitting excess fluid vertically away from the wound bed. In addition, another significant benefit of this product is that wound exudate will not wick horizontally, preventing peri-wound maceration, which is a common problem with gauze products as they wick in all directions. Calcium alginate is available in flat sheets as well as rope versions. The product does not adhere to a wound surface, so removal is atraumatic. As noted on this slide, calcium alginate and hydrofiber dressings may be used in the presence of moderate to heavy exudate. Applying it to a wound with minimal exudate will dry out the wound bed, impairing healing. As you can see from this slide, foam dressings are available in various shapes and sizes, as well as formulations. Basic foams are usually made from polyurethane, however, other materials are also available. The products may or may not have adhesive borders, and the amount of moisture that evaporates through the material varies based on the composition of the outer layer. In addition, they are more resistant to overspray. Some are more resistant to overspray of water from the outside, thus allowing some to be worn when showering. Foams generally do not absorb as much exudate volume as calcium alginates, but there are some exceptions depending upon the material. Peri-wound maceration can be a concern with foam dressings, so a peri-wound skin protectant is an option to consider. The foams with adhesive borders are convenient, as a secondary dressing would not be needed, nor would tape around the margins to keep them in place. Hydrocolloid dressings differ from all previous mentioned dressings in that they promote healing by autolysis. Rather than absorbing the wound exudate and all of its beneficial components, namely proteolytic enzymes, the enzymes and wound fluid are retained under the dressing, promoting the lysis of non-viable tissue, which of course is the target of the enzymes. These dressings are also available in various shapes and sizes to accommodate various body locations, as well as various thicknesses to accommodate varying amounts of exudate, or to effect a change in dressing change frequency. Hydrocolloid dressings are commonly used in the treatment of pressure injuries in the sacral and ischial regions. Hydrocolloid dressings have several unique characteristics that make them either ideal for a certain patient or absolutely contraindicated. As noted in this slide, if autolysis is desired as the preferred form of debridement, then a hydrocolloid may be the best choice. Simply stated, wounds are essentially bathed in their own exudate, which can be desirable to achieve autolysis. In the presence of incontinence, hydrocolloids will absolutely protect the tissues under the dressing from stool, urine, and other debris. However, the listed contraindications must be respected. Peri-wound skin protectant is highly recommended before applying a hydrocolloid, and that will reduce the incidence of peri-wound maceration. By now, you're assuming that there are various shapes and sizes to all the dressing categories, and you're correct. If you're human, you've had some form of a non-adherent on your body at some point in your life. The image in the upper left gives away my point. That small white pad on the adhesive bandage is a non-adherent. But there are other types of non-adherents as shown here. The lower left product is a type of gauze coated with a petrolatum and other ingredients, often used by some surgeons over an incision that's been enclosed primarily to prevent the gauze secondary dressing from adhering to the suture line. Other versions are made from a synthetic mesh coated with petrolatum or more recently silicone. Whichever product is used, the end result is for a dressing that can be removed without trauma. One of the main differences in products in this category is how easily exudate can move through the non-adherent. Some are more porous than others, which is a significant aspect to consider, as retained fluid over an incision will likely contribute to maceration and dehiscence of the incision. If a non-adherent is used over an open wound, the intention again is to avoid trauma to the tissues, whether that is to avoid pain, avoid bleeding with someone who's anticoagulated, or when used over fragile tissues of a skin graft or biologic tissue graft. The hydrogel category contains products that are either in sheet form or in an amorphous form, which simply means a gel formation. The gels have varying amounts of moisture that are meant to maintain a moist wound surface, which could be used to prevent a healthy wound bed from drying out, or to moisten a bed of non-viable tissue to promote autolysis. Standard hydrogels are fairly inert, but others, as in the case of honey-based gels, have active ingredients that will change the pH of a wound environment, supply mild antimicrobial effects, and or change the osmolarity of the wound environment. The range of indications is broad, from healthy to non-viable wound tissue. We must always attend to the peri-wound tissue so as not to prevent peri-wound maceration. The moist environment of a wound gel promotes autolytic debridement as mentioned previously, when combined with an appropriate secondary dressing, which is often gauze. Transparent films are often used for the purpose of securing intravenous dressings. They too are available in various shapes and sizes and have the convenience of allowing one to monitor the skin beneath it due to the transparent nature of the product. Transparent films, unless combined with an absorbent product, do not absorb wound exudate and will simply slide off if fluid builds up underneath them. They may be used with minor skin tears, but care must be taken to remove them in the proper direction so as not to reopen the wound to not reopen a recently adhered skin flap. Based on the information in this slide, you can understand that transparent films do not play a major role in the management of partial full-thickness wounds. They do protect the skin from the effects of friction, such as that experienced at the elbows and heels when in bed, but do not offer any relief of pressure. Okay, this is a pretty exhaustive description in this slide. The world of antiseptics and antimicrobials has a long history with recent significant advances in efficacy and specificity. You may remember your parent pouring hydrogen peroxide over your knees after scraping them on the sidewalk and the agony you endured. That solution may have been effective in cleansing the wounds due to the effervescence. However, it also was cytotoxic to healthy tissues needed for healing. Fortunately, when we're kids, our powers of healing are much more robust than in later years. Other antiseptics that have been used in use for wound healing include Dakin solution, which is a dilute bleach, and acetic acid, which is the active ingredient in white vinegar. As antiseptics, they have specific activity, but again, they are considered too cytotoxic for long-term use in wound healing. You are certainly familiar with the povidone iodine products used as a broad-spectrum antimicrobial, as a skin prep for surgical procedures, better known as betadine. It's very effective as a skin antiseptic, however, because of its significant cytotoxicity, especially to fibroblasts, it is not recommended to be used in the course of wound care, if healing is a goal. A modern formulation of iodine, a low molecular weight cadexamer called iodosorb, is a sterile formulation of cadexamer iodine. When applied to the wound, iodosorb cleans it by absorbing fluids, removing exudate, slough and debris, and forming a gel over the wound surface. As the gel absorbs exudate, iodine is released, killing bacteria and changing color as the iodine is used up. The advent of silver ion as an antimicrobial, although added to modern dressings, was used hundreds of years ago in water supplies. Today it's added to several of the products I've already presented, including calcium alginate, foams, gels, and even compression stockings. Silver is a broad-spectrum antimicrobial, and it's not associated with allergic reactions to the extent that is present with iodine products. And lastly, research has demonstrated that bacteria very successfully produce something referred to as a biofilm, which is essentially a community of organisms that are protected from the body's immune system by a fatty layer of cells. Up to 90% of chronic wounds have biofilms. These biofilms cannot be destroyed by conventional means, including the use of antiseptics and antibiotics. Rather, biofilms must be mechanically debrided to remove them. However, biofilms can reconstitute themselves within 24 hours. Newly developed products are able to break down a biofilm and protect it from reforming. The slide demonstrates one of these products. Successful wound healing may require the use of any of the products previously mentioned. It's recommended to consult your local infectious disease staff if considering using such products when a given wound demonstrates any of the cardinal signs of inflammation, if traditional interventions are not successful. These include thorough irrigation, debridement, aerobic and anaerobic wound culturing, as well as tissue biopsies, and other standard wound care procedures. So far, we've discussed the use of dressings to support autolytic debridement. However, another form of debridement is available via an ointment, which contains an enzyme, namely collagenase. The enzyme digests non-viable collagen without harming viable tissues. The enzyme is formulated with petrolatum. As such, the enzyme requires water or saline to be activated. Covering the ointment with a saline moistened gauze allows the enzyme to interact with the non-viable tissues. The enzyme has a half-life of 24 hours and should be applied daily. Wounds that would benefit from the use of an enzyme will progress best when also treated with sharp debridement on a regular basis. As noted here, the collagenase ointment requires a prescription. It's the only active enzymatic debriding product on the market in the United States. Now, for a complete change of focus for a moment, I'll present some very basic concepts related to management of edema using compression. The decision to use compression must be made only after a very thorough assessment of a person's vascular status, including their arterial, venous, and lymphatic systems. If wounds are present, especially in the lower extremity, the vascular evaluation is essential to not only healing the wounds, but also to the viability of the extremity. The presence of certain wounds may be a direct result of peripheral vascular disease, and the chances for healing may largely be dependent upon appropriate compression management. To do the topic of compression management justice, entire courses are offered on the theory and practice of managing edema and/or wound healing with compression. As that's not the focus of this presentation, I encourage you to learn much more about the science and application of compression for the benefit of your patients. In summary, it's important to remember that since wounds are expected to change, hopefully improve, over time, the type of dressing needed to continue to promote healing will often need to change with it. We must match the dressing to the wound, not the wound to the dressing. We can be successful in our attempts to heal wounds if we pay close attention to the characteristics of the wounds themselves, the feedback from our patients, and objective data. I encourage you to be creative as well as pay attention to the details, as the practice of wound healing is as much an art as it is a science. Dr. Gary Sibbald said it best: we must always treat the whole patient, not the hole in the patient. I appreciate your attention. Thank you.